I would like to invite chairperson of the session, Dr. Elankumaran sir, for management of OSD with cataract.
Thank you, sir. Uh, can you have the slides, please? At the outset, I'd like to thank the scientific committee for giving me this opportunity. Why should we ever, say 20 years back, we were not even discussing about dry eye in cataract surgery. Now look at this particular study where all dry eyes can happen anytime, dry eyes can happen anytime, starts immediately after cataract surgery and increases, peaks at around 1 week, stays for around 4 to 6 weeks and then reduces. Why should we even bother about a dry eye in such a situation is the question, but this is the answer. Because almost 87% here and 85% of people here presenting for cataract surgery have subclinical dry eye. They don't know. And after we operate, come after 6 weeks and keep complaining about it. Hence, a surgical society, ACRS, finally gave a survey to its participants and asked, what do you want from this? This was the answer. We have a lot of studies, but it is confusing. Too much of data is there. We don't know what to do. Hence, ACRS decided to start a committee to come out with a report and prepare an algorithm what should be done in cataract surgery if the patient has dry eye, or how to prevent dry eye after cataract surgery. Now, any algorithm should be consensus based. It can be incorporated easily into practice, reduce the chair time of the surgeon, and most importantly, in this case, we should be able to classify it visually significant or not. We would have done an exceptionally good surgery, but thanks to the dry eye, our IOL power would have gone erratic because of the changed keratometer reading. Even if we put the top of the IOL, because of dry eye, he'll have poor quality, and there is a higher chance of infection in these cases. Hence, what are the things to do? Pre-operative, intraoperative, post-operative, and the treatment. That's how I've classified this particular talk. So this was the algorithm that was proposed. Now this is what, in short, it's a non-invasive surgery planning, and if necessary, a possible repeat is required. Most important part of this algorithm was this: it's idiot-proof. Even your receptionist, even probably watchman, if you can train, can do this. It also says where to start and where to end. It says start here. The point to be noted here, if at all, if you have touch the patient, put paracaine or touch the patient, wait for 2 hours before you start these readings. And the first thing what you do is take the readings of the IOL power. That's what is the first thing to do. Then you give a questionnaire, and in the questionnaire, also, while taking these readings, teach the optometrist to look for these kind of findings. Any inferior steepening which cannot be explained, or any distortion of the Mayas indicate dry eye. Give a questionnaire to the patient. What was used here was the speed questionnaire, which they had modified and called it speed 2, wherein they had just added these questions related to the cataract surgery, whether the patient is willing for multifocal advanced IOLs, whether he can pay out of pocket. This is effectively the speed questionnaire with this modification, and then subject the patient to examination. They said you do osmolarity, you do MMP, all these kind of things. We don't have access to it. So what I do in my practice is look for the aqueous volume height, tear volume height, less than 0.1, 0.1 to 0.25, above 0.25. 0.1 to 0.25, approximately in the mind we can make out that is normal. Anything below or above is abnormal. Even with a simple AR, we can look at this, do work as a mybographer, look at the meibomian glands, and then proceed, decide on the patient. Of importance, LLPP, look, lift, pull, push. Look out for any abnormalities of the gland, of the eyelid margins, and then decide whether this patient has dry eye or not. Now, after deciding whether this patient has dry eye, we should find out whether it's visually significant or not. Now, visually significant, I teach my optometrists, what do I tell them? If a person after a blink, if that keratometry changes by more than 0.5, then this is significant. Ideally, it's 0.1, but 0.1 we can't measure, so 0.5, this is significant. This is what I teach them, and they look out for that. And if there is any staining, finally stain this patient, this is a visually significant where you have to treat this patient. If these 2 points are there, then defer the cataract surgery, treat the patient for dry eye, and then take him off. If it is not there, directly you can go ahead with the cataract surgery. How long to defer? 4 to 6 weeks. Point to be noted here, be very careful. If you leave it for 4 to 6 weeks, it will go to the next clinic. But then please explain to the patient and then go ahead with the surgery. This is the algorithm. Intraoperatively, we all know why we get dry eyes. Dry eye, we are traumatizing the nerves, so try to reduce this nerve damage. The 2 mm incisions are best in these cases, and during the surgery, reduce the ocular trauma. Do not catch hold of the conjunctiva, pull, push, tear the conjunctiva. Reduce the repeated drying and irrigation. This is another thing which we miss out. Reduce the number of preoperative drops. We put a lot of anesthetic drops. Reduce the time that is taken so that the phototoxicity is reduced, and of course the surgical trauma. Post-operatively, what do we do with these patients? What is the regimen that is prescribed? Now, this is a study wherein they classify the patients into these 4 groups. Group A, only steroid antibiotic combination. Here it was tobramycin and dexamethasone which was used, not any of our advanced things. Group B, they added a mydriatic. Now, that we do not do in most of our phacoemulsification cases. Group C, they added NSAID, Nepafenac, and group D, they added carboxymethyl cellulose. Simply said, just look at this group D. Always it was performing better as regards the Schirmer and BUT, as well as the patient's response to pain, least pain in the group 4. Most of the other things also recovered towards after 6 weeks, but the initial period, adding a lubricating drop is best thing to do with cataract surgeries. Now comes the question, cyclosporin or not immediately. Now look at the study. It says that cyclosporin, if used, is definitely better, but then what do practically we do? If there is dry eye, then we use it preoperatively at least 4 weeks before and continue for 6 months after cataract surgery. Something which has been lingering on your minds during our ECCE days or the early part of phaco days, dexamethasone we were using and we never had dry eyes. That's what we thought. But then again, there's a study to prove, because prednisolone has more incidence of dry eye when compared to dexamethasone. However, dexamethasone alone is not enough. Only now we are not getting it. So dexamethasone is the preferred drug over prednisolone acetate. Use of NSAID, if possible, avoid it. Do not use it for all of them. And if you have to use it, use the single dose or the 2 times a day, such as Nepafenac or Brownfenac, which is once or twice a day. And even if there is a slightest doubt, refer to the corneal surgeon, because melting is seen in these kind of cases. Very novel thing which says ocular surface frailty index. Initially, they looked at these 19 different parameters and said which is the best correlation. Later found these 10 parameters. I'm not going into complete details because this itself will take 15 minutes. These 10 features are what predisposes a patient to dry eye. So if he has any of this, look at this patient with concern. And what they said was this value, 0.3, 0.25 to 0.3, they took as a cutoff. If OSFI is more than 0.25, 0.3, they said treat this patient vigorously before taking up. As regards treatment, we know what DUSE 2 says. Let's not too much into it. Only thing, it is look for symptoms. If there are no signs, look for symptoms. Be aggressive with the treatment. And only point which I would like to say, follow this nomogram, but if the patient is even grade 2, I would like to initiate grade 1, here I'd like to initiate grade 2 treatment, that is 1 step above. Normally, whatever we do 1 step above for these kind of patients. These are the algorithms to use. Now comes 2 questions. I'm a clinician. I don't have access to all these things. What do I do? Asia Pacific Dry Eye Society has proposed very well, wherein they have classified the staining patterns into area line, random, and spot or dimple. Based on this, you can make your diagnosis, because aqueous deficients are more prone to more dry eyes after surgery. So here, if you look at it, these random breaks, these are the commonest which is found in evaporative type. This area break or the line break, simple staining can give you these results. These are found in aqueous. If you find any of these 2, treat aggressively. And more importantly, if you find something like this, which we find very, very rarely, I have not seen much, in these kind of cases, it's a wettability issue. That is also a significant issue. So random break, you can ignore. They also suggested use of these 2 drugs, which we have used and not found to be very thing. Summing up the treatment, it is use not just the lubricating drops, immune modulators, steroids, NSAID, go aggressively with punctal occlusion, which many of us are not doing nowadays, but it's very good. If need be, if it is meibomian gland thing, use tetracyclines or macroglides. Now, final question. I'm a clinician. What should I use? In all these cases, of course, it's multifactorial. In all these cases, the commonest thing is a lubricant. So let's concentrate on what to use for this. I've got this study. There are multiple other studies. These are called multi-actions. Cause for dry eyes, it has been listed there. Tear film stabilization, corneal epithelial, cytoprotective action, increased mucin accretion. If you look at all these things, It's only serum which acts everywhere else, and the only other drug which acts is that is hyaluronic acid, which is marked top. But the CMC with Trahelose, if CMC is combined with Trahelose, it can give the similar kind of action. Just last 2 slides. And this slide also reiterates that when you look at actions, it's better to use a multi-acting drug. And look at here, now, CMC, HA, CMC, HA, but CMC, HA, but this is where it scores. So hyaluronic acid is more of a multi-action drug, and that would be my preferred choice in treating dry eyes with cataract surgery. Thank you for the opportunity.
Thank you so much, sir, for excellent presentation. Sir, do you think like the incisions which we used to do 10 years back, like 2.8 incisions, and now we have shifted to 2.2 incisions, does it has any effect on your like patients of dryness?
Definitely, sir. The smaller incisions have lesser incidence of dry eye. Not only this, the superior incisions again have a slightly lesser incidence of dry eye. And third, very important thing is shelved incision, which we do 3 planar incisions, have more incidence of dry eye than a uniplanar incisions.
Okay. And second thing, like before doing keratometry, do you like dilatation of the patient occurs after doing the keratometry?
That is one fallacy, sir. So if I diagnose a patient with the cataract, I get the cataract investigations done based on his vision itself, based on the vision and the refractive readings. I get it done, then dilate this patient. If a drop is put, we have to wait for 2 hours before initiate.
Thank you, sir.
Thank you. Sir, thank you. We started half an hour late, sir.
I can understand.
Thank you.